Hi, everybody. Glad so many of you could make it today. And it's at the top of the hour, so I think we have a lot of information to cover, so we are going to get started. My name is Carla Haravi, and I work with PayerWatch and with Adam. And today we're going to be discussing, experts discuss the key points and impact of the 2024 Medicare Advantage final rule. And we do have some housekeeping to take care of. So on the screen, you should now see, you should have a control panel, and it should show you a little bit about if you want to join, excuse me, if you need to open or close your control panel. There are handouts where you can download handouts. And then down at the bottom is where you can submit questions and comments. And we will do our very best to answer questions at the end of the webinar, provided that there's time. As far as CEUs and contact hour goes, free CEUs, as always, are offered to Atom members only. To obtain the CEUs, if you're an Atom member, you must attend the live webinar for at least 50 minutes and complete the survey. The survey will pop up automatically for you at the end of the webinar. We will email the CEU certificates to you. And unfortunately, they're not available for just watching the recording of the live webinar. And a disclosure, no individuals in a position to control content for this activity have any relevant financial relationships to declare. Now, once the survey comes up, you'll be prompted to select the CEUs that you desire, and you can choose as many as you want. And we have an upcoming webinar coming, complimentary, successfully defending inpatient authorization denials, and we hope you'll be able to join us on July 19th at 2 p.m. And again, the CEUs are for Atom members only, and you can register at the Atom homepage, which is www.atom.org. A little bit about Atom. The Association for Healthcare Denial and Appeal Management is the nation's only association dedicated to healthcare denial and appeal management. Our mission is to support and promote professionals working in the field of healthcare insurance denial and appeal management through education and collaboration. Our vision is to create an even playing field where patients and healthcare providers are successful in persuading medical insurers to make proper payment decisions. And Atom is created through the generous support of PayerWatch. And just a little bit about PayerWatch. PayerWatch Appeal Masters is the service part of the company, and thousands have been trained in denial and appeal management. We also write appeals for clients across the country. We believe in taking your appeals the entire way, as far as you can take them. And we also encourage a clinical legal approach. PayerWatch Veracity is a software side of our company, and the software is a leader in the industry, and it was created to be a service to providers to protect revenue. Something I need to read. The Association for Healthcare Denial and Appeal Management, Atom, publishes and distributes materials on its website that are created by our members or invited industry subject matter experts for the benefit of all Atom members. Atom does not certify the accuracy or authority of these materials. These materials are distributed and presented as research information to be used by Atom members in conjunction with other research deemed necessary in the exercise of Atom members' independent professional judgment. Atom claims no liability in relation to reliance on the content of these materials. The views expressed in the materials are the views of the materials authors and do not necessarily represent the views of Atom. Any references are provided for informational purposes only and do not constitute endorsement of any sources. There are no conflicts of interest to declare for any individual in a position to control the content of this presentation. I'd like to introduce to you Denise Wilson. Many of you are familiar with Denise. She's a Senior Vice President at PayerWatch and Appeal Masters and President of Atom. Denise has over 30 years of experience in many, many things. And she has extensive experience as a medical appeals expert, has personally managed hundreds of managed Medicare and commercial appeal cases, and presented hundreds of cases at the ALJ level. She's a nationally known speaker and dynamic educator, as sure many of you know. Dr. Carolyn Dutton is board certified internal medicine and emergency medicine. She completed medical school at St. George's University School of Medicine and her training at Allegheny General Hospital, my backyard actually, where she served as chief resident. And she's worked both in emergency medicine and as a hospitalist with Atrium Health since 2006, and continues to work clinically as a medical director for University City Wound Care Center, serves as the director of operations for Atrium Health Physician Advisor Services. She's also board certified in healthcare quality and management, is chair of the American College of Physician Advisors, Government Affairs Committee, and serves on the ACPA Board of Directors. Welcome, Dr. Dutton. Busy lady. Dr. Kendall Smith, he's a senior fellow in hospital medicine. He currently acts as chief physician advisor for PayerWatch and Appeal Masters. He's deeply involved in denial and appeals management throughout his hospitalist career, has served as physician leader in hospital revenue cycle management teams, and also serves as physician advisor for clinical resource management. Dr. Smith is also an AHIMA approved trainer and ambassador. Bill Haynes serves as a legal director of the clinical legal unit and is managing attorney for PayerWatch and Appeal Masters. Bill is a member in good standing of the Maryland Bar, a member of ADAM, and a member of the American Health Law Association. Bill has a ton of experience in healthcare law, including managed care contract analysis, payer-provider arbitrations, and the independent review processes. Bill personally manages a team of attorneys at Appeal Masters. Okay, our learning objectives for today. At the conclusion of the webinar, the learner will be able to self-report that they can summarize two major provisions of the 2024 Medicare Advantage and Part D final rule, how the final rule will impact their work, the effective date for most services, and how to provide feedback regarding MAO noncompliance. At the conclusion of the webinar, at least 90% of participants will share in the evaluation the ability to identify 3 ways to provide feedback regarding MAO noncompliance with the final rule, identification of 2 major provisions to the 2024 to the final rule that impact case managers, utilization management nurses, and nurse appeal writers, and when the final rule goes into effect. And with that, I'm going to turn it over to Denise, and she'll start out with an overview of that final rule.
Hey, thanks, Carla. So I just want to be sure that we're all kind of on the same page and you are clear with what we're talking about today, because we always get folks who are kind of new to this arena. So let's just do kind of a quick overview of the final rule. So going back to April of last year, the Office of Inspector General, the OIG, issued a report on Medicare Advantage organizations. And what they determined from this audit that they did was there was concern over whether some Medicare Advantage organizations might be too restrictive in granting requests for care, and they may be not providing care that a member would normally get under traditional Medicare. And so the concern was that some of the MAO organizations might be delaying or preventing beneficiaries from getting care that they would have gotten if they'd been under traditional Medicare. So they made some recommendations to CMS and said, one of the things they said was, we don't think CMS has been clear enough on what they mean by Medicare Advantage organizations not being allowed to be more restrictive than CMS. So in August, then CMS issued a request for information on a proposed rule that they published, and they received a huge number of comments submitted back, almost 4,000 comments, and that's not only from providers but also from patients as well. And I have links to all of these reports and the comments page. If you haven't taken a look in there, the links are at the end of the presentation today. You can go back and look at that if you didn't do it in real time or at the time that it was published. So, this wasn't anything that was new really to providers. We all, were welcoming this intervention from the OIG and CMS's response to it. And so there were a lot of comments submitted. In December, CMS put out a proposed rule, published their proposed rule. Got some comments back on that, not nearly as many, because of course they published it during, the holidays, which is, Medicare's timing is always impeccable. And then in April 5th of this year, they issued their final rule. So the final rule says it has an effective date of June 5th, 2023. But then it also says it has an applicability date of June 1st, 2024, except as otherwise noted. So there's been some confusion over when does this final rule go into effect. My interpretation is that they have noted the exceptions that go in earlier, that go into effect earlier than January 1st, 2024. If you just read the first paragraph in the published rule, it will talk about things like marketing of MAO plans. It talks about prescription drug pricing and things like that, or coverage, prescription drug coverage. So my take is that as far as the things we're going to talk about today, that those will go into effect January 1st, 2024. So that's one of the questions on your survey. So don't let that trip you up. The effective date for all intents and purposes for what we're talking about today is going to be January 1st, 2024. But my opinion is there's no reason why you couldn't start including that in some of your appeal language or peer-to-peers now. All they can say is we don't have to abide by that until January 1st. But there's, no harm, in my opinion, of starting to get used to arguing the final rule in your appeals now. Okay, next slide. So one of the things that I wanted to talk about is some of the traditional Medicare rules that have always been kind of in disagreement between payers and providers. One is the 2 midnight rule. Do MAOs have to follow it? And the other is the inpatient only list. So this final rule did clarify or reaffirm that MAOs cannot be more restrictive than traditional Medicare. It affirms that the inpatient only list applies to the MAOs. It affirms that the MAOs must follow the 2 midnight benchmark as well as the case-by-case exception. So the 2 midnight benchmark is the understanding that the physician caring for that patient feels that this patient has made a clinical determination this patient's going to require at least 2 midnights of hospital care. That's their benchmark, and all of that is well documented in the record and supported in the record. The case-by-case exception is when the physician feels that the patient may not require 2 midnights of hospital care, but because of the clinical complexity of the clinical situation, inpatient admission is appropriate anyway. So that's case-by-case exception. There's also a presumption that goes along with the 2 midnight benchmark, and that is for auditing purposes. So traditional Medicare says they're going to presume anything greater than a 2 midnight admission to the hospital that physician made the right call in determining the patient's going to require more than 2 midnights, and that is documented in the record. And so generally they're not going to audit those cases. That does not apply to Medicare Advantage. They're allowing Medicare Advantage to do the auditing in the way that they feel is appropriate for their services. So the presumption does not apply. And Kendall's going to talk about, Dr. Smith's going to talk about that during his part and give us kind of a short case study of that particular presumption benchmark terminology and process. Okay, so that's it for me. I'm going to turn it over to Dr. Dutton. Happy to have her here to help talk about what does this rule mean in your day-to-day operations and in real-life physician advising.
Right. Thank you, Denise. Good afternoon. Thanks to all of you for joining us today. I will go ahead and start with a disclaimer. If anyone has and suffers from insomnia, press your record button now. You can play this back tonight as you're going to sleep. I have tried to condense, the final rule that came out was over 700 pages, and I've tried to condense about 100 pages of that down to the next couple of minutes, so I'll do my best. As many of you know, and as Denise mentioned, the final rule was published in April. It's also known as 4201. And this rule does address many facets of care, but today I just want to discuss some of the highlights and their impact on functions in regard to Medicare Advantage organizations. These plans, just in case you're not aware, are also referred to as MAOs, MA plans, coordinated care plans. You'll hear several of those terms mentioned. The rule does discuss traditional Medicare, which is also known as fee-for-service Medicare or original Medicare, and how these benefits apply to MAO enrollees. So how does this translate to the average physician advisor? In regard to utilization management and medical necessity, the rule states that MA plans must cover the same basic benefits as Part A and Part B fee-for-service Medicare, with the exception of hospice and kidney acquisitions for transplant. That is, MA plans cannot deny or limit basic benefits. CMS states that the coverage criteria and benefits include, they apply to acute inpatient care admissions, they apply to home health services, skilled nursing facilities, as well as inpatient rehab. It codifies that MAOs must follow the 2 midnight rule, as she mentioned. A question that came up earlier, it was regarding how a plan contract comes into play with the 2 midnight rule if there's a contract with the provider. In general, it's my understanding that contracts cannot be more restrictive than the law. However, I'm going to defer this to Bill, our attorney, later on in his talk for further comment. I'm sure he'll have a lot more to say about that. I would also add that the final rule does not dictate how the plans will decide which claims they're going to review. Regarding inpatient admissions, CMS confirms that the criteria listed in the Federal Register on prospective payment systems for inpatient hospital services will apply to MA plans. This can be found in section 412.3. The rule notes that MAOs must apply the same inpatient and outpatient definitions as fee-for-service Medicare. And given the importance of these definitions, I'm going to briefly read the salient points in case you all aren't familiar with this document. It does say that for the purposes of payment under Part A, an individual is considered an inpatient of a hospital, including a critical access hospital, if formally admitted as an inpatient pursuant to an order for an inpatient admission by a physician or other qualified practitioner. It goes on to state that an inpatient admission is generally appropriate for payment under Part A when the admitting physician expects the patient to require hospital care that crosses 2 midnights. It should take into account complex factors, which I'm sure you're all aware of, patient's history, comorbidities, severity and signs and symptoms, current medical needs, and the risk of an adverse event. It also goes on to add that in an unforeseen circumstance, such as the beneficiary's death or transfer, results in a shorter beneficiary stay than the physician's expectation of at least 2 midnights, that stay may still be considered appropriately treated on an inpatient basis and for payment under Medicare Part A. The rule notes that MA plans must also follow national coverage determinations, NCDs, as well as local coverage determinations if there are any applicable in that plan service area. It notes that if there is no NCD or LCD, the MA plans may create their internal coverage criteria. They note that the criteria must be based on current evidence. They note that it should be available in widely used treatment guidelines or clinical literature, and they specifically cite randomized controlled trials or cohort studies, and they state that the plan should apply the same methodology that Medicare administrative contractors follow when they create NCDs and LCDs. They note that information considered in making these decisions must also be publicly available. They do not specify, however, how that public availability process should occur. And they also note that criteria that are in case studies or only that the plan has identified internally, that level of evidence would not suffice. MAOs also may not use commercial screening products to change coverage or payment criteria, which is already established under traditional Medicare laws. MA plans need to make medical necessity determinations based on internal policies that are, again, no more restrictive than traditional Medicare. They may not deny authorizations based on internal clinical criteria that go beyond Medicare coverage rules. They go on to state that MA plans cannot adopt policies and procedures, which would result in denial of services, which fee-for-service Medicare would cover. They do, however, offer some flexibility to the plans in supplemental benefit coverage. These are things that Medicare doesn't routinely cover, your Silver Sneakers membership. In regard to the inpatient-only rule, as Denise mentioned, according to this final rule, they did state that the coverage of an inpatient admission for a procedure, which is found on the inpatient-only list, is fully established under the applicable Medicare regulations, and the MA plan must cover this type of inpatient admission without additional internal criteria. And I wanted to highlight one point that it talks about regarding SNF. And while it didn't change the law, as you know, MA plans do not require a 3 midnight inpatient stay for discharge to a skilled nursing facility. The final rule didn't change this. However, it simply changed the location of where to find this. There is now a section titled Medical Necessity Determinations and Special Provisions. And this section will contain special rules for MA basic benefits that don't conform to traditional Medicare. In regards to post-acute care authorizations, they note that the plans can only deny if traditional Medicare criteria can't be satisfied in that particular setting, be it a skilled nursing facility or rehab. They also note, once again, they can only use internal coverage criteria if there are no applicable Medicare statutes, regs, NCDs, or LCDs. Next slide, please. In terms of prior authorizations, CMS notes that prior authorizations can only be used to confirm a diagnosis or criteria for coverage determinations. They can only be used to ensure that a treatment is medically necessary. They also note, next slide, that the authorization should span the treatment course to avoid any disruptions in care. And they do specifically prohibit new prior authorizations for a period of 90 days if someone's undergoing an active treatment course when they switch to a new plan during open enrollment or when the new year starts. So that's good. Next slide, please. And the final thing in regard to basic utilization management functions, the rule establishes that MA organizations need to establish a utilization management committee with several basic underlying features. It doesn't specifically say if it should be at the plan level or the parent company level. It's going to allow the company to determine that. But they do state that they need to employ a medical director to ensure clinical accuracy of all the organization determinations and reconsiderations involving medical necessity. They also note that these committees are required to meet at least annually to review all policies and procedures, as well as any pertinent guidelines and specific guidelines pertaining to Medicare, NCDs, and LCDs. It does note that the majority of these committee members should be practicing physicians. At least one of them should be independent and free of conflict relative to the plan. It also notes that at least one should be an expert in the care of elderly and disabled. And they do encourage the inclusion of an enrollee representative, which I think is a good thing. And then they also, the final caveat is that after January 1st, they cannot use any policies that haven't been previously approved by the committee. So thank you very much for your attention. Now Dr. Smith's going to discuss the additional coverage criteria and retrospective denials.
Thanks, Carolyn. So it's Dr. Dutton kind of alluded to, this is a sort of a significant sea change with respect to truing up the playing field for Medicare Advantage plans and the rights and of patients enrolled in these plans. There were some specific, and this may echo a little bit of what Dr. Dutton said, but let me go into a little deeper discussion. Interestingly, CMS in its preamble to the final rule actually specifically singled out intercall and MCG systems, and they took a very dim view of Medicare Advantage plans sort of blanket utilization of these tools to deny care and cited them by name. Medicare Advantage plans per CMS were not allowed to, never anticipated that they would use such products to change coverage or payment criteria already granted under traditional Medicare coverage requirements. And I think one of the important things to note is that these commercial tools could not be used if medical necessity determinations are based on an algorithm or software that does not adequately account for an individual's particular circumstances. And I think that's a really significant issue to realize that, you know, these blanket one-size-fits-all denials that don't take into account the fact the patient may be homeless, may have significant comorbidities, et cetera, will no longer fly. So for a Medicare Advantage plan to use a coverage criteria in these tools, actually the plan needs to be able to explain the external clinical evidence that they're relying upon, and as Dr. Dutton had said, make this publicly available. They did say the use of these tools in isolation without the compliance from the other requirements set forth in the final rule is going to be strictly prohibited. And so this starts to raise the issue of, you know, what's the impact of this going to be on UR, and how do those of us that are involved in denial management, when we want to cry foul, escalate these claims? Because I think it's going to be really important moving forward that we keep CMS apprised of any payers that may not be complying with the final rule. We know that from experience, complaining to the payers themselves often falls on deaf ears. Although I will tell you from experience, if you're able to get into their compliance department, you may be able to have an informed discussion and get some leverage or a toe in the door to start to talk about what you perceive to be as lack of compliance, but we'll provide you some other avenues going forward. Next slide. So going back to the 2 midnight presumption, and let me share a case with you that actually came across my desk a week or two ago, which was timely, involving a Medicare Advantage beneficiary. You know, we said earlier that the 2 midnight presumption is what CMS uses to determine the medical necessity of inpatient care. This does not necessarily apply to Medicare Advantage plans, and I can break this down into a denial that I looked at last week, which was a patient that had come in, their care had passed 3 midnights, and the MA provider retrospectively denied inpatient care. You know, one of the points on appealing this case was the fact that the patient, the beneficiary, had been in the hospital over 3 midnights. The MA's response was, well, that's all well and good. They came in on a Friday and sat in the hospital to Monday waiting for their cath. You know, had this been provided timely, they would in fact stayed 1 midnight, and not, you know, there was not an expectation that this patient would in fact have spent 2 midnights in the hospital due to lack of services being available. So the lesson learned from this is that your 2 and 3 day stays are going to continue to be audited and looked at closely by the MA plans. Just as quite sometimes they're done by RAC, but you're really going to need to tighten up your utilization review programs to keep track of these things. So if just the presumption and certification that the patient's going to require a 2 midnight stay, if in fact they're not meeting medical necessity for those 2 midnights and nothing's happening with them, probably going to lead to audits and takebacks subsequently that you'll need to be aware of and account for. And the argument that the patient spent 2 midnights doesn't really carry weight unless there was it was medically necessary for their care. So just parking the patient for 2 midnights isn't going to get you an inpatient check from an MA plan. Next slide. So you can always file a grievance with the plan. Getting a hold of the plan's compliance department, which Bill Haynes probably talked about a bit, and we found to be useful. There are mechanisms to file grievances internally with the MA plan. I think, and Carolyn, you can agree, I think you probably got greater experience with this with your program, since we're seeing patients denials after the fact. Is probably the biggest battering ram you're going to have is to get the patient involved in the denial process and having them call Medicare and complain. That they're being denied care, that had they not taken this Medicare Advantage plan, would have been paid for under traditional Medicare. They understand that the hospital is, they're trying to force you into observation. They're disagreeing and not going to pay for the care, and they believe that, or they had a friend that had traditional Medicare and this care was provided for, sort of thing. Or providing a narrative to the patient to give to Medicare can be incredibly useful. CMS definitely takes notice when patients are involved in the process. And Dr. Dutton, I think if you just want to comment.
Yeah, very much so. I do think that CMS puts greater stock in feedback that comes from enrollees versus a hospital complaining they didn't get paid, right? So I think, people should focus on whether or not the plans are following the rules. And I think I would definitely encourage members to provide feedback. Again, a lot of times if it's just a hospital filing a grievance with the plan, it may fall on deaf ears if it's deemed as this is just a payment dispute. And I think lastly, if you're concerned about the way the rules and regs are being followed by the plans, or you think that it may not be being followed according to the rules, I would submit your questions to the Part C and Part D mailbox, the appeals mailbox, which the address is listed on this slide. And then finally, you can always reference your state's Department of Insurance and discuss with them if there's an issue.
Thanks. So I'm going to turn this over to Bill Haynes, our legal counsel, for additional comment.
Thank you, Kendall. Let me start by saying I'm PayerWatch's attorney. I'm not your attorney, so this isn't legal advice. If you need legal advice, talk to your own attorney. But I'm going to talk about specifically the regulatory, the changes in the specific language of the regulations, highlighting two that Dr. Dutton and Kendall both went over. But I want to go over the particular changes in language that occurred and why I think it's both useful and notable that this happened. I'll quickly also refer back to the question we got earlier that Dr. Dutton mentioned. Your contract with a Medicare Advantage provider, your contractual status is important on two very important extents. They are required by the law to have their policies and coverage follow all of these regulations. But the law is very clear that the statutory appeals process is only available to non-contracted providers. That is it. Beneficiaries, non-contracted providers get access to the statutory process. If you have a contract, you have your contract process. So try to make sure that if you have any influence over the people who are negotiating your contracts, make sure you try to get good terms for dispute resolution, because that has a very real impact. Now going back to the regulations. So any of you who've been to a couple of our prior webinars on this subject will know that, or have spoken to me offline about this, will know that in my opinion, a great deal of the proposed rule was taking existing guidance language and elevating it to the status of a rule. And I had serious questions about how effective that would be in terms of its impact on payer behavior. That is, we still have to wait and see what impact it will have. But I have to say that having read the changes in the language, I am more hopeful than I was on previous webinars about this. And I'll go over why with, again, highlighting two particular sections. So going to the requirements relating to basic benefits, this is 42 CFR 422-101B, and specifically B2, you'll see the prior language was, this is, when I read this, I see this as hand-waving language. You can imagine someone saying, general coverage guidelines, including original Medicare instructions unless superseded by regulations in this part are related to other instructions. You can imagine a government bureaucrat just repeating that and waving their hand as a kind of dismissive motion to be like, yes, whatever's in the law and the guidances, and then whatever we say. It's very broad in a way that sounds helpful, but as I think everybody's seen for over a decade at least, if not more, is not actually helpful. The new language, which again is in the regulations as of the 5th of this month, but will apply to coverage starting January 1st of next year, that language is much more clear. So here it is, general coverage benefits and general coverage and benefit conditions included in traditional Medicare laws, unless superseded by laws applicable to MA plans. This includes criteria for determining when an item or service is a benefit available under traditional Medicare, for example, and then it provides examples. Dr. Dutton mentioned these examples before: inpatient admissions, inpatient care, SNF, home health services, IRF, etc. This language is much more clearly lays out. It's not very broad languages about, anything in the manuals, unless we say otherwise. This is traditional Medicare laws, unless it says differently in Medicare Advantage laws. This does include coverage criteria for specific items and services, and it gives a list of examples that you can use if you're arguing against a payer, on either on the specific examples or something that would be similar to the specific examples and are included as a coverage criteria. So that gives you much more to work with. Vague language like the prior language seems helpful because it seems to cover a vast, but then when you actually have to argue the point, you have so little to grab onto. This is much more clear. You're able to say, is it in traditional Medicare laws? Yes. It's not superseded by the MA plan, then it applies. Done. You don't even need to go any further. If you're dealing with something that's covered under the example, you can say this is an example that they have in the regulation that says it's supposed to be covered. Now, again, this draws originally the guidance that the previous language meant to include in its broad language. This draws from the Managed Care Coverage Manual, Chapter 4, 10.2. This is the first sentence of a multi-paragraph explanation of what's meant to be covered. Plans have to provide what's in A and Part B and so on. And again, this was meant to be in that whole section, which is fairly detailed in multiple paragraphs, is meant to be included into the law by that prior language. But again, it's so vague, and you're dealing with a guidance, which is itself not law, being incorporated by vague language into a rule that is law, that in the end, it turned out not to be very helpful. This, again, I think is much more clear language. In the long run, this should give providers, I think, a much stronger ability to argue against the reasons that payers give for denying care. Next slide, please. This was also mentioned by Dr. Dutton, I think also by Dr. Smith. So this is, again, 422-101B6. This is about internal coverage criteria. So this is a new section. There was no prior language here. This was just in the guidance. Again, Chapter 490.5, titled, I think very unhelpfully, Creating New Guidance. It was about internal coverage criteria, and one of, again, this was several paragraphs, but it mentioned that internal coverage criteria could be used in coverage situations where there was no NCD, LCD, or guidance on coverage in original Medicare manuals. And that's really all it said. It wasn't terribly helpful after that to say when specifically they were allowed to use these criteria, and gave, again, rather unhelpful descriptions of what could be used. And there was at the time no public accessibility requirement at all. Now, in 101B6, they spell out that yes, they can use these criteria in the situation, but public accessibility is required, and it's required that the coverage criteria are not fully established. And then they have separate specific definitions for both of those things. I didn't include those here because of space, but I encourage you to go look up 422 101B6, their subsections under that language that define publicly accessible and coverage criteria not fully established. Again, it is language that for public accessibility didn't exist before, and then is more clear in its definition of what constitutes coverage criteria not fully established. And you want to familiarize yourself with that language, particularly coverage criteria not fully established, because I assure you, whenever you say that a payer is violating that part, they're just going to say, no, we're not. It's not fully established. And they're probably going to give no explanation as to why. No evidence. They're just going to say, no, it wasn't fully established, so that's why we're deciding this. And you need to be familiar with the language to say, it's not, that it was fully established. You're incorrect. The definition is this, and this is why you didn't meet that definition. And having that ability to have access to this language that is in the regulations and in clear language, again, I think will be helpful in the long run to giving providers a much better ability to make clearer arguments against payers, not only against the payer themselves, but also against third parties, arbitrators, ALJs, whoever, if there's an independent review entity, anybody else. This familiarity with this language should give providers much greater strength with those arguments. So thank you. I'm going to turn this back over to Carla. Hopefully we have time for some questions.
Thank you so much, everybody. That was incredibly important, and I think incredibly useful. So I want to thank each of you so very much. Okay, let's see if we have some questions. We do have some time, and Denise volunteered to help with the questions, which I was happy about.
Hey, I just want to make a couple of comments before we get into the questions that, I think we've touched on something that's really going to be really important in the next year, and that is the fact, we're starting in January, and that is the fact that we don't really know how CMS or how well CMS is going to monitor MAO behavior after the first of the year. So what Dr. Smith and Dr. Dutton talked about as far as how you complain if they're not being compliant, if you don't believe they're being compliant, and how they're to behave, and Bill's explanation of the regulations. And so I would just encourage you to make sure, read everything you can, go to all the webinars that you can that are discussing this. There's been a lot of discussion out there in the community. I'm sure there's blogs and all kinds of things that have been published on this, and will probably continue to be published for a while. And just make sure that you're well educated in it and well versed in it, because we're part of the monitoring that behavior. We probably monitor it much more closely than CMS, just because we're living it every day, and we know what the MAO plans are doing and not doing. So that's one thing that I just would want to say about this whole situation, is to make sure you're doing your due diligence. Yeah, Bill?
I'd add to that. It took, 23 plus years to get to this final rule. I mean, these original rules for Medicare Advantage were put in place 20 years ago. And in that original language, there was language that the MA plans couldn't be more restrictive than traditional Medicare. taken 20 years of complaints, challenges, and feedback. And I think the community has done a really good job in the past 3 to 4 years of coming together and escalating these things that we let 10, 15 years go by where people were getting, trod upon, and finally started to push back in an organized manner in the past few years. And it did take a number of us by surprise when this came out abruptly. And I think it took a lot of the people in the industry by surprise that all of a sudden CMS seemed to have sat up and take a listen to things that we had been talking about for years. And I think the number of complaints coming in and from the number of places they were coming from finally got their attention. So let's keep the pressure on going forward. If you suspect you've been fouled, by all means, call foul, get the referee into the game to take a look at it, because it took us 23 years of complaining and arguing and everything else to get this final rule that's not perfect. There are loopholes that are going to exist in it. We'll see what comes out of it, but by all means, stay vocal. So.
Yeah, I would echo what Dr. Smith says. I mean, from what I heard, the time period from this to come out as a proposed rule to when it became a final rule was one of the shortest times on record. The other thing is I would encourage you to, keep all your denial letters, read your denial letters, often what you're seeing in the letter, and then when you call the plans, what you're told on the phone with the plan doesn't necessarily reflect what's in the letter. I would just encourage everyone to keep taking it to the next level until you get a satisfactory response. Don't give up.
Okay, Carla, did you want to read some of the questions, or do you want me to kind of go through those?
I'm having a hard time seeing all the questions, to be honest.
Okay, no problem.
Okay, thank you.
Yeah, so we have a question about okay, first let me just say there was a comment that MCG is doing education for payers regarding misuse and misrepresentation of their product. And I have seen some things out there where MCG and Interqual, of course, they have some skin in the game and want to just make sure that everyone is using their products appropriately. And we're not here to bash Interqual or MCG, either one. They definitely have a place in the process. And so that's good to know that they're also, there to support our providers and make sure that everything's being used appropriately. Okay, so Cindy says, I've done grievances for regulatory. I find payers tend to ignore the regulatory portion and just review Interqual and MCG, and I have to escalate for payers to look at regulatory and compliance issues. So yeah, I think that's probably fairly common, that especially when you do your if you're going through the appeal process, you're going to see that they're not going to they're not going to look at your concerns about regulatory compliance issues until you move it up the chain. You guys agree or have any comments on that?
Yeah, I think the language is now a lot stronger, as we've all mentioned, than what it had been previously. But again, I think if you're concerned that they're not following the regulatory guidelines, I would submit that back to the Part C and Part D mailbox to get a final answer on that. I don't know, Kendall, you?
Yeah, I'd agree. And I think, if your submissions can be in bulk, the extent that you can take 10 or 15 from a payer and show a pattern, you're much more likely to get the attention of CMS than if you send them in one at a time. So if you can send in 10 or 15 cases that are similarly situated, that show a common violation of a statute, you're more likely to get, I think, some feedback.
Yeah, I think part of this is just inertia. They're so used to not having to really concern themselves with regulatory things until it's pushed up, and many providers don't do that. It needs to be done. It needs to be done often until they are forced by the government or by the cost of having to go up every time on every regulatory issue to incorporate it at the base level. They won't do that until it affects their bottom line.
Okay, a question for our docs. The new rule, just to summarize, this person says, this attendee says, just to summarize, the new rule allows us to make a patient inpatient once they pass the 2 midnight benchmark, but we can't presume it will be paid for, as they may come back and deny it for medical necessity. Is that correct? So Kendall, you talked about.
Yeah, essentially yes. There's got to be, just because the person's sitting there for 5 days, came in and needs placement and has got a 4-day stay, and there's really no medical necessity for inpatient, that's going to continue to be looked at and audited and then recouped. So your processes, roadblocks to care and things don't count, in the 2 midnight consideration. There isn't a reasonable presumption that you're going to need 2 midnights of inpatient care for a patient coming in Friday. Nobody's going to see or act on until Monday. That really, in all fairness to the MA providers, I think they are within their rights to come back and recoup those cases.
CMS has been pretty clear that they don't cover custodial care. So
Yeah.
Things like, we can't take care of her anymore and she needs to go to a nursing home, probably not gonna fly, even if it takes a week to get her to a nursing home, if they're on their same oral medications and nothing differently is being done, and you're just feeding them. So,
but that is an issue that you can deal with contracting, because CMS, as I said, they're not going to pay for it. But Bill, you could contract language for custodial care into your MA agreements at a different rate, could you not?
Yeah, the law is in most places of concern a minimum requirement.
Okay.
You try to get more favorable language on just about any issue, and particularly when it comes to areas of coverage and dispute resolution, you want to get as much as you can.
Right. So yeah, it's, Medicare Advantage and traditional Medicare are on the same page as far as what the docs have said, is that it still has to be, the patient still has to require care that requires a hospital, stay in the hospital for that 2 midnights. It just means that that traditional Medicare is generally not going to come back and audit those. They have to audit them if they're going to deny them. They've got to look at what's documented in the medical record in order to, if they're going to issue a denial for the 2 midnight rule. So generally, Medicare is not going to audit them, but MAO plans can. Does the language cover rules and regulations around readmission denials? Do Medicare Advantage plans have to follow Medicare's definition of preventable readmission? I don't think that was in the, I'm sure that's not in the
did not
rule.
specifically see reference to that.
No.
Here, I have a question here.
Go ahead.
When coverage criteria is not fully established, what is publicly accessible internal coverage criteria?
So that was when CMS did not define how it should be made publicly accessible. It did state that if there was not a national or local coverage determination and there was no pre-existing Medicare laws governing that, it would allow for the plans to develop their own internal coverage criteria. As I mentioned, it did require that it be high-level quality evidence coming from things, and they specifically listed randomized controlled trials and things of that nature. It did cite that, a one-off case report was not sufficient evidence. It also stated that things that were found internally only within the plan would not suffice as evidence.
Bill, put you on the spot is a quick question with that. And you can kill me afterwards for asking this. But is consideration of the FDA approval process, if you have an FDA approved device and indication, sufficient to argue back against a MA's plan sort of non-coverage? If there's, let's say, a discrepancy or looseness in an LCD or NCD, they've made a determination that they're not going to cover something that's FDA approved. Is that?
I would say it could be used as evidence that it should be.
Okay.
Whenever something to keep in mind when you're making arguments is that being a lawyer is not about memorizing the law. It is about learning how to apply the law to facts and then making arguments about it for or against any situation. So don't assume that because the MA plan is making an argument to you, perhaps from their lawyers or based on information from their lawyers, that that argument is definitely correct and you have to accept it. If you think there is evidence to the contrary, use that evidence and say, no, I think you're wrong based on this, and this. And if you're talking to them, maybe you'll be talking to a brick wall. But if you're talking to an ALJ or you're talking to an arbitrator, then maybe you'll get further. And hopefully, if you are going that far, you are involving your own attorneys, either internally or external counsel for that purpose, who can assist you with that. But if you anything that seems like valid evidence that your point is correct, bring it up. If you're appealing, if you're arguing back, whether it's in a written appeal or in a JOC or in just an informal discussion with the payer about your relationship or about particular cases, bring up evidence that you have that you think is reasonable to bring up to say, this should be covered.
I would
okay with this. Why aren't you?
Make sure you bring it up early. I would add
as early as you can.
As early as you can. You want to get it into the record. So if there is a de novo consideration, like an ALJ, where someone's going to look at the totality of the record, they can see that you raise this issue early on. There's rules as to when you can submit these things. When you get to the ALJ level, it's often too late to submit a contrarian position or an evidence to the contrary of the payer's position. So, your first level response should be your best out of the gate. So dig in, read what they're saying. As Bill said, take it with a big grain of salt. And if common sense tells you that that's you're being fed horse hockey, then by all means do some research and rebut it. So at least it's in the record, if and when you can get an independent review of the facts.
Yes.
Okay, I have another one here, and we still have a couple minutes. So, can missed prior authorization for outpatient treatment for MA beneficiary be retro authorized, or does a hospital need to go through formal appeal submission?
Not sure I understand the question.
Yeah.
Okay, I'll read it again. Can missed prior authorization for outpatient treatment, so they didn't get an auth for an outpatient.
So they failed to get a prior auth. Okay.
Or an MA beneficiary. So they're asking, can it be retro authorized, or does the hospital need to go through formal appeal submission?
That's going to depend on their contractual status, I believe, Bill. Would be something you'd comment on, whether they're in network or out of network with the payer as to what their appeal rates would be. Would that not be correct?
Yeah, if they have a contract, it would be based on what the contract says. If they're not contracted, it would be based on policies. The one thing to remember, though, is always that if something is what's legally defined as emergency care or urgent care, that needs to be provided regardless of authorization status. It just has to be provided, and they're not even allowed to tell their patients or their providers to ask about prior authorization regarding those two things, emergency or urgent treatment. And then if it is emergency treatment specifically, any stabilization care, that also has to be covered without prior authorization. And then anything after stabilization, if it is the maintenance of stability or post-stabilization care based on an original emergency treatment, authorization for that must be given within an hour of contact. And that hour after contact must be covered. And if it is not responded to within an hour, it is considered, they have to pay it. They are considered to have agreed to it. So keep in mind those two types, or those three types of treatment. Emergency and urgent must be covered. They're not even allowed to say you need to prior auth that. And then maintenance and post-stabilization, they have to respond within an hour.
And I will add, if you're contracted, a lot of contracts will allow for a medical necessity appeal in the absence, if you could demonstrate medical necessity, if there was no prior auth, you can usually appeal in that regard. But that would be up to your contract.
Right. Yep.
Well, thank you, everybody. We are at the top of the hour. So I want to thank everybody who participated in the webinar, the speakers, as well as those of you out there in the audience. We do have references here available for you because it was a lot of information, and there's a lot more. And we want to thank you all again very much. The survey will pop up immediately after you close out of the webinar. Okay, hopefully we'll see you at the next webinar.
Thank you.
Thanks, everyone.
Thanks, Denise, Carla, and Bill.
Yes, thank you.